So I'll start with some introductions. Good morning, my name is Nicole Tuzi. I'm a program manager with Infant Mental Health Promotion at the Hospital for Sick Children. A bit about my background. So my education is in early childhood education. I worked frontline for a long time, did a lot of school age, and then I moved over to the 0 to 3 population. And before coming to this position, all of 6 months ago, something like that, I had operated a childcare within a children's mental health agency in East Toronto. So lots of experience there working with children who actually do require additional supports. And so today is about learning about those developmental support plans and how we can support children moving forward. I think what's really going to be important that comes out of this training today is that, so for those of you who are familiar with developmental screening and are doing it, it's a wonderful tool. It's fantastic to have a sense of where do we go next, but then you actually need to have a next step. You need to know where to actually go. And many of us have to stop at a referral. We may make a referral to where we believe the next step is, but then we have all this waiting time. And this is the really important piece of our developmental support plan, is that it gives you and families something to do right now. We're going to do a short little Cole's Notes version of infant mental health basics, and hopefully what you come away with from that is that brain development is so rapid in these first 3 years that we really have to capitalize on that time. And so when we don't have resources available to us readily that are going to support children's development right out of the gate, right when we understand that there's a concern or a problem and wanting to stop it from manifesting into something much larger, we often don't have those tools, particularly in Canada. We don't talk about this age group as often as we should. And so the hope, what we're starting to find with our hand-in-hand resource in particular is that we are seeing children make gains before they even get to more intensive services. And that's a big win for that age group, for families, for practitioners such as yourselves, and certainly for society at large. So of course, we'd like to acknowledge the traditional lands that we are on for the Hospital of Sick Children. We reside in the territory of the Huron-Wendat and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit. The territory has been occupied for the past 15,000 years and was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. The name Toronto has many meanings, including the Mohawk word Toronto, where there are trees and water. We are thankful to work in this territory and gratefully acknowledge past, present, and future Indigenous peoples who call Toronto home. I also want to extend this acknowledgement beyond a land acknowledgement. The Indigenous population is incredibly important to our office. And today's presentation is, we'll talk a bit about some of the science that we've come to understand about brain development and infant and early mental health, but this isn't new to the Indigenous population. This is very old knowledge. This is common sense to that population. And I also wish to acknowledge that there are many ways of knowing. And in this sense, I'd also like to acknowledge that this is just a Western view. And I encourage you to think about, if you are working with the Indigenous peoples, to consider their perspective and to really hold true their stories when you're working with this population. This knowledge has been held by these people for many, many, many generations. And we are currently working with our Indigenous partners throughout Canada on a study. And so today's presentation will talk to you about Hand in Hand, which is more our mainstream piece, but we'll also be giving to you our Nurturing the Seed, which is actually specifically developed for the Indigenous population. And we didn't create it on our own. It was certainly co-created with an elders council that we had put together so that we could make sure that the strategies and the goals and the perspectives are culturally appropriate. Because we know that different people do different things, right? And we want to make sure that any strategies that we're giving for families are going to be meaningful and that they're actually going to do them and work and be able to support their children in that. All right. So first things first, we have to kind of have this conversation about mental health versus mental illness. And as you can see on our smiley faces to help. When we look at this continuum and when we talk about mental health, people often say, oh, I don't have mental health issues, or I don't have mental health. Well, we have capacity for mental health. And what I think we really need to focus on is that just because you may have mental health just because you may perhaps have mental illness doesn't mean that you don't have good mental health. And just because you have a lack of mental health doesn't mean you also don't have a lack of mental illness. So there's a continuum there where we can actually see that the absence of mental illness doesn't actually mean the presence or practice of mental health. You could have a diagnosis of anxiety or depression, but you put things in place for yourself that support your ability to manage the day and to manage the things in your life. And so part of what a developmental support plan is really wonderful is that it's actually putting into practice some of those pieces so that you can ensure that you are getting through your day-to-day life. So what is infant and early mental health? Oftentimes it's referred to social emotional development, and it's really focusing on the developing capacity of the child from birth to 5 years of age. And it includes these three really key components. A child's ability to form and secure adult and peer relationships. Relationships are number one. The ability to experience, manage, and express a full range of emotions. And I want you to think about how you as an adult kind of go through your day. You use all of the skills that you've developed up until now to manage when you have something that doesn't go your way, and you're able to ebb and flow throughout the day with those emotions. And we need to be able to build those skills in children as well. Nobody is happy all the time. That's exhausting. Anybody watch The Crown? No? There's an episode where young Queen Elizabeth is on a tour, and it's something like 23 weeks long, and every single day she has to be in a car and she's waving and she's smiling all the time, the whole day. And she actually has to go see the doctor to get an injection because there's a twitch in her face because she's just smiling too much. It's not all that healthy on the other end of things. It's the ability to move through all of those emotions safely. And the last piece around that is the ability to explore the environment and learn. So when you have secure relationships, when you're able to manage all of your emotions, you're in a better position to explore and learn and fully participate in your world. Sorry, I'm Italian, I use my hands, it might hit the mic. So social emotional development used to be considered this one massive, umbrella. This one overarching piece. Oh, this is a child that might need support with their social emotional. But now we actually have the ability to kind of break down social emotional development into 7 specific behavioral areas. We can look at self-regulation, we can look at compliance, communication, adaptive functioning, autonomy, affect, and interaction with people. So these are all components that if you are using the social emotional 2, actually comes with a cheat sheet. Those who are using the SE2 know of that cheat sheet?
We have it in the packages.
We do have it in the packages. We can take a look at it a little later on. But what the cheat sheet does, it actually corresponds one of these behavioral areas to every actual question in the social emotional 2. And that way, when you're going through your social emotional 2, you can actually identify how many high scoring questions pertain to any particular behavioral area. And from that, you can determine, okay, when I'm creating my developmental support plan, am I going to focus on communication? Do I need to focus on affect? What about interaction with people? Where exactly is this child requiring support from their social emotional realm? Okay. Happy to go through that later on today if people are interested. So what makes infant and early mental health challenging? Babies don't talk. They don't use the same exact language that we do. They cannot tell us what's going on. They can show us in many different ways, and we try to interpret that, but they don't have those words. Cues can often be really, really subtle. And again, harder to interpret when children are demonstrating behaviors and we're trying to interpret those, what they could possibly mean. What does that child need? And oftentimes when we look at children's behavior, because that's the big communication piece for us, we're thinking about what has just happened in order for this behavior to occur, but we may not be considering that what just happened might have been the straw that broke the camel's back. We're not considering all the things prior to that behavior that could impact that incident, for example. So are we asking questions, or are we thinking about the child's family history? Are we talking or thinking about what are the experiences this little one has had in their life that in this particular moment they're having some trouble? Could we learn more about how this child came into this world? Are we having conversations with families about their lives as well? The other thing that can sometimes be difficult is differentiating between developmentally appropriate behaviors and behaviors that are terribly concerning. So in my experience, I've gotten a lot of questions around biting in particular. That seems to be a favorite. You know, this 2-year-old is biting. Well, we don't want the child to bite, of course, because that has consequences for other children or other people. But at the same time, we have to recognize that biting at 2 years old isn't about maliciousness. It's about a child exploring the world. Everything kind of goes in the mouth, including children who decide to stick their fingers in other children's mouths, right? So what is developmentally appropriate versus what is terribly concerning, right? And that also looks at intensity and frequency of certain behaviors as well. Once in a while, not so concerned. Happening all the time, perhaps you're a bit more concerned. So what does that mean for you in the room? So due to their dependence on adults, infants are among the most vulnerable people. They rely on us for absolutely everything, for meeting all of their basic needs and protecting them from the world. And they are at the highest risk for a lifetime of poor outcomes physically, emotionally, and cognitively if we don't have certain things in place to support that protection and meeting those basic needs. They need us to be a champion for them and to be their voice. Because again, they're not speaking. This is a really important concept to me because we can't do this all on our own. And parents can't do this all on their own either. There is a village, or there needs to be a village, and sometimes there isn't. And recognizing what your role is in that village is really, really critical. Because sometimes, especially for this young group, because they haven't hit formal schooling, the only eyes on are the people in this room, quite often. And so you kind of have to act accordingly, knowing that you might be the only person in the village. And can you make considerations for who else could be in the village? Who are you going to bring on your team to help support this child or this family? This is just a small list of those you can consider, particularly when you're creating a developmental support plan. If you know that you're making a referral for a child and you're bringing in another resource, say an occupational therapist, you know, could you and the family and the occupational therapist sit down and actually come up with this developmental support plan so parents are getting the same message? And so that all the systems in place for this child are actually working together with a shared vision. You're going to hear me say this a lot today. Relationships. You're going to get so sick of me saying it. Relationships are absolutely critical. We cannot move forward with working with children and their families if we do not have relationships being built. It is as important as good nutrition. That's a fact. We know that relationships influence how the brain is being built, the structure, the function, the architecture. We know that relationship could be the single most important protective factor a child has. We often see children who, despite the odds, are doing well, And if you look a bit more closely at those children, they often have champions right behind them at every step of the way. They have people in their life who are helping them combat those adversities, left, right, and center. And we know that relationships drive development. So at a time when the brain is so incredibly vulnerable, but also so incredibly remarkable in how rapid it is growing and developing, those relationships could not be more important at this time. Infant and early mental health can prevent later mental illness. We're quite confident in being able to say that because we know how important those relationships are and how truly early intervention plays a huge role in actually making sure that we reduce or prevent entirely mental illnesses that can come later on in life when they go untreated. So this is a little chart. Anxiety disorders, ADHD, substance misuse, conduct disorders, major depression. And some of these disorders are actually happening or being diagnosed or being reflected in the data at as young as 4 years old. But nobody turned 4 and all of a sudden had these concerns. This is stuff that's been festering over time. And we have no data for the 0 to 3 population in particular. It's just an age group we haven't done a lot of science on. And so it's really important for us that if children are developing these disorders and by the time they hit kindergarten, they're already having concerns, what's happening prior to this age, prior to formal schooling? What are we doing before then to support these young children? And for those of you, there's a whole heap of you in this room that are working with that population. This is really important that you're here. It tells me that you're very committed to this because you absolutely can make a difference. So the outcomes of positive early mental health. At the center of all of this is a secure attachment. And self-regulation, resilience, and optimal brain development can only come from a solid foundation with a caregiver. All of these pieces come together to actually promote positive physical and mental health and children's overall success, the ability to thrive. So what is attachment? Attachment is an infant's tendency to seek comfort, support, nurturance, and protection from a small number of caregivers. Remember once upon a time when cell phones still charged you for all your calls and you could pick your 5 favorite people, right? Or your top 10 or whatever they are. Who did you put in there? You're allowed to speak, I promise. It doesn't have to just be me. Parents, friends, people that were really important to you. People you know that when you call them, they're going to pick up, they're going to address the issue that's going on. These are the people that you go to when something's happening in your life, good or not so good, right? And so that's the important piece around secure attachment. Every child needs one. It's that much more beneficial when you have your top 5 or your top 10, or even more so. Your Instagram followers don't count. So what builds a secure attachment? So the single most important thing to remember about how to build a secure attachment is that the caregiver always responds to the child's distress. Always. No matter what that distress might look like. No matter how trivial it may seem. And if it's not happening in a sensitive or appropriate or consistent or timely manner, then it's not building a secure attachment. Any one of those 4 pieces that are missing from that equation does not promote itself to that secure attachment. You could be sensitive, you could be appropriate, but if you're not doing it all the time, it becomes unpredictable. And you could be sensitive and appropriate and consistent, but if it's happening 30 minutes after I've been crying, not so timely either. "23% of infants worldwide have a disorganized attachment." Are we concerned by this number? this is a very scary number. Worldwide, almost a quarter of the infant population has a disorganized attachment. So why are we concerned about this? Because a disorganized attachment is the attachment style that is linked to psychopathology. And so those 25% or so of infants grow into 25% of youth and 25% of adults who are going to struggle throughout their life. It's problematic for them, and it's certainly problematic on a societal level as well. So what can we do to support those children before things become really, really challenging? Yeah. So this is work coming out of Sherry Madigan at the University of Calgary. And she specifically looks at, we've referenced the paper. I'm not quite sure exactly how she did her research, but they had looked at a global perspective on that. So attachment is the foundation for regulation. And so why is regulation important? It influences our emotional and behavioral response to the experiences that we encounter. So we always can't control what happens to us or in the world around us, but we have to be able to manage from our perspective, right? You know, how many times have you heard that saying, you can't control what happens to you, you can only control your response. But if you don't have those skills, controlling your response is going to be really, really challenging, and it may be the wrong response or an inadequate response, which could have consequences further down the line. So having those self-regulation skills lends itself to executive functioning, which are mental processes that enable us to plan, focus attention, remember instructions, juggle multiple tasks or multiple instructions, being able to filter distractions and prioritize your tasks. So getting here at 8:30 a.m. was really, really hard. And you had to make sure that you had done certain things. You know, maybe you set out your clothes the night before in order to prioritize for this morning, or maybe you just shoved on whatever was clean. You know, who knows, whatever. But the point is that you could plan and prioritize for today because you needed to be somewhere at a certain time to do a certain thing, and you're able to do that. Children who have challenges in this are going to be the ones that show up late or not at all, not be prepared for what's happening next. The other thing is that these are lifelong benefits, right? These skills are crucial for learning and development. They also enable positive behavior and allow us to make healthy choices for ourselves and our families. How many of you have heard of someone saying to a small child, you know, you should know better? Our prefrontal cortex doesn't actually develop until you're about 25 to 30 years old. So when we're telling a young child you should know better, I kind of laugh and say, no, not really, not necessarily. This process of co-regulation has to, this process of self-regulation, which is the end game goal, starts with co-regulation. And they're not going to learn that until we do that with them over and over and over and over and over again. It is a skill that continues to build, I mean, truthfully, all your life. And again, it goes back to that timely, sensitive, consistent, and appropriate response. So another piece of this is resilience. So let's watch a short little video on that.
Resilience is the result of a highly interactive process between individual characteristics in the person and the environment in which that individual has developed.
It's really the counterbalancing of difficult things that may exist in the child's life with positive things that occur within the family, but even positive things that may exist in the community.
An easy way of thinking about resilience is like a scale with a fulcrum in the middle of it. And there are things on both sides of that scale, experiences of both bad things or good things.
Our genes shape where the fulcrum is positioned at the start.
There are certain genes that make a child more sensitive to the effects of maltreatment or parental neglect or witnessing violence.
The fulcrum may start out kind of more towards one side or more towards the other side, and that's going to make a big difference in terms of how much these subsequent events affect things positively or negatively.
Science tells us that experience moves the fulcrum, for better or for worse.
Even though we are born with genes, genes will respond differently to certain environmental situations as opposed to others.
What the genes are actually doing are turning up or turning down the expression of chemicals in circuits in the brain and the circuitry in the entire body that govern our responses to stress, to anxiety, to depressive symptoms.
When positive experiences accumulate and children learn coping skills that help them to manage stress, the fulcrum can slide, so the scale tilts toward positive outcomes more easily. That's what resilience is all about.
There's always an adult, or more than one adult, who is key to providing that relationship that helps to build resilience.
So children who do well in the face of serious hardship typically have biological resistance to adversity and strong relationships with the important adults in their family and in their community. And as you can see through that little video, you can see it really is a combination of those protective factors that are going to support a more positive outcome. What is temperament? Do people often think about temperament in their work? I see some heads nodding. We did this presentation not too long ago, and people were actually, they knew about temperament, but they didn't often consider it. And this is actually a really important piece, because temperament isn't just about recognizing the child's temperament, but certainly how it meshes with your own. And how does that impede or support the building of a relationship? So temperament is actually one of those few things that we actually say that whatever temperament you're kind of born with generally tends to stick throughout your lifetime, generally. And so it's really important that we recognize the temperament of the people that we work with in order to, as adults, flex our own to support the relationship and support the development of that child. So we look at all these pieces. The other piece is around goodness of fit, and that's where the adults, the onus is on us to do the bending and the flexing when we're working with families and children in order to build that relationship so we can actually work with the family moving forward. You know, I've experienced in my own work that can be quite challenging when you and a parent in particular don't see eye to eye. But I have to keep that relationship or else I lose that family altogether. So how can I flex myself in order to keep that family on board and work very, very slowly, perhaps towards my end goal, but making sure that I'm taking into account what's valuable and important to that family member as they want to move forward in supporting their child. This is a scale that you can find. You can Google this, you can find this, it's quite easy. And I actually encourage you to do it for yourself when you're coming into a bit of conflict with either a family or a colleague, but certainly getting parents to do this as well, to help them understand that their temperament and their child's temperament sometimes can clash. And that's okay, but again, we have to support parents in recognizing where can they flex, where can they bend, in order to continue to build that secure attachment with their child, because that's going to be the driver of all of their development. If the relationship is ruptured for whatever reason and is around the temperament, right? So perhaps I'm a very outgoing person. My child is very shy. That impedes my ability to go out and do things. I have to consider what's best for my child. So I might have to make considerations around when I go out, how I introduce that child. Is it small groups? Is it large groups? I might have to keep all of those pieces in mind. And getting families to kind of see where they rank on this scale might give them a better understanding of who their child is. Because their child is a person right now. They're not just turning into one later on. So infant and early mental health this is a time in a child's life where it is the greatest opportunity to influence developmental outcomes in the first 3 years of life. Something that's really, really interesting, and a lot of this presentation can be doom and gloom, but what I really want to emphasize is that this is a tremendous time for opportunity. We have 1 million synaptic connections happening per second in the brain in the first 3 years of life. This is unmatched at any other time in a child's life. And so we really do need to capitalize on this. And we can capitalize on this when we're working with children and families. So it's really, really important to be inundating that child with those positive experiences so that their brain is being developed in a way that is going to lend themselves to success later down the line. So let's look at a little bit of this is synaptic connections that are happening as a newborn, a 1-month-old, a 3-month-old, and at 6 months old. So you can see as the newborn, they're just starting to kind of proliferate. And at 1 month, we see a lot more connections, and it continues. And look at the activity that's happening for that 6-month-old. Look at how many synaptic connections are there. We're born with all of the ability to learn, for example, all the languages in the world, but our brain is going to hold on to the ones that we're actually hearing and experiencing. So if we're not hearing a language, for example, so if we're only hearing English, and we're not hearing Thai, our brain is going to prune away those bits. So you can see what happens at birth. We've got a little bit going on. At 6 years old, this is where we see a lot of activity. And then the brain starts to prune away. And sometimes people often think, oh, well, as they get older, there should be more. But the brain is actually strengthening the ones that you have and letting go of the ones that you don't need or use to make room for the connections you have built. So you got to use it or you're going to lose it. Now, that's not to say that the brain isn't so remarkable that even until much older, your brain is able to take on new things. It's just going to require a lot more effort. So as you can see here, the brain's ability to change in response to experiences starts to really decline quite rapidly around the 8-10 year mark. And the effort that's required for those changes, again, where your prefrontal cortex is maturing and pretty much done developing, becomes that much more difficult. So not impossible, just far more challenging. And I often say this because I have that EC background, that you may have staff or colleagues that their prefrontal cortex is still developing. We have ECs that do come into the field at quite a young age, right? And so it's even really important to recognize that in yourself. Where are you in your development when you're working with children and families? This is my favorite slide because it has the little dots that bounce around. I'm very mesmerized by this. But it just gives you a little depiction on how quickly those connections are being made and how many connections are happening at one time simultaneously. So the quality of those interactions that we have with every child will influence these connections. Last week, I was at a conference around literacy consultation, and we talked about how could we best support families in recognizing and promoting literacy in their young children. And a lot of people talked about, oh, just talk, just speak. But it's not just talk and speak or sing. It is the quality of the words and the annotations that you're using in your conversation. So the quality and the positive input of those interactions for building relationships is absolutely critical. It's not just any relationship. Children will attach to anyone in their life regardless of the quality of that relationship. We're trying to make sure that it is positive. It's caring, it's warm, it's responsive. Has anyone seen these? Positive, tolerable, and toxic stress? Some, yeah. So some stress is actually positive. We need stress in our lives to a degree to motivate us. For example, getting up in the morning to come here. That little bit of stress, if we got to be here at a certain time, is important. It's a motivator. It could be the stress that you kind of experience if you're at the gym or working out. It's short-lived, and it has a positive effect. Then there's tolerable stress, where it's serious, but it's temporary. But tolerable stress only exists if there is a buffer. If there is no buffer, we go straight to toxic. So a tolerable stress could be the loss of a family member, for example. It is serious, it is devastating, but it's temporary if there is someone to help support through the grieving process for that child. If nobody comes forward to work with that child or to understand or console that child, this has the potential to be quite toxic. And toxic stress produces that awful little hormone called cortisol that actually kills brain cells when it's prolonged and frequent. So what does that do to our brain architecture? What does that stress do? So as you can see at the top, we have a normal picture of what a typical neuron looks like. Lots of connections, looks like a strong connection. It's a little bit thicker. But when we're experiencing toxic stress, those neurons become damaged and they're weaker and they're not as strong. Which brings us to epigenetics. Has anybody heard the term epigenetics before? Perfect. The indigenous population calls it blood memory. I actually like that term a whole lot better. It makes so much more sense to me because it is actually about how your experiences and the experiences of the people in your family and the generations prior to you actually impact your own DNA and your own response to the world. And I think it's really important to know, if we come back to that slide around your context, you're not just working with one child or one family. Your work with children and families has the power to impact generations beyond the one child that you are working with or the one family that you're working with. So know how important it is that the service that you're providing to just one family has an impact on generations. So consider how many families and how many children you impact over the course of your own careers. It's pretty profound. It's a little overwhelming if you really think about it. But it also just demonstrates how important your work is. So how I like to look at it is through these two little diagrams here. So if I came into the world with pretty good DNA, my family prior to me didn't experience a whole lot of adversity, I'm coming in with DNA that's going to be pretty strong. And so if I happen to face adversity, I'm better able to manage it because I have those pieces in place from a DNA perspective, but also from a supportive relationship perspective. For children who are coming from generations, and I do specifically look at our Indigenous population that have endured years and years and years and generations of adversity and trauma, their DNA, once it's impacted by further adversity, continues on. And so they have a saying that when we are trying to make change, we look 7 years back and we look 7 years forward, because that's how long it's going to take to elicit change. So we know that stress actually affects our health, and here's why. So this is a piece of DNA, and at the very end, you can see those red little caps. Those are called telomeres. And when I think of telomeres, I think of, you know, the little piece of plastic on the end of your shoestring? Those are there to help protect the integrity of that DNA. But as we age, they naturally decline. So as you wear your favorite pair of sneakers in the snow and the water and whatnot, it tends to get a little bit destroyed, but that's expected because you're using it. But if those caps are destroyed not just by you wearing it and going through life, but perhaps you have a dog that likes to chew on the ends of them, and that's your stress, then those caps erode that much more quickly and compromise the integrity of your DNA. And they also impact your overall physical health. Children whose telomeres are shorter are sicker more often, and we see them in hospitals more often. So just a quick little infographic that recaps that your genes, in combination with your experiences, are going to create those epigenetics, that blood memory, that impacts the brain architecture, the structure, and its function, and that further impacts your learning, your behavior, and your overall health. So trauma-informed care. This is going to be a critical piece of the work that we all do when we're working with families. And it's really looking at an approach that requires the practitioner to actually have knowledge about the impact of trauma. You don't necessarily need to be able to treat it, but it's going to change the way you actually work with families and children if you have a better understanding of how trauma can impact development. The focus is really going to be on creating a safe environment. You know, oftentimes we see families and children come to service and they have to retell their story over and over and over and again, and that's exhausting and it's re-traumatizing. And we need to find better ways to elicit that information because it is really important to our work, but how do we do so in a safe and really humane way? And again, we go back to relationships. So if you're seeing a family for the first time and you're meeting them, are you going to sit there with a clipboard and ask all of your really intrusive questions in a very clinical way? Is that the best way to get information? No. You may get information that you need because sometimes families are just worn down by the process. They're just going to tell you the same story they've told everybody else. But when you build relationship and you actually have conversations over a course of time, you're going to get information that you never thought you needed. And they're going to tell you things that they don't tell anybody else. And it's going to be those nuances in their life that are going to help you support the growth and development of their family and of their child. It's going to be really important. So why is that trauma care piece important? Because it actually influences the interactions we have. It changes that. And I think this is the other important piece. To be trauma care informed, you don't have to have clinical skills or use clinical skills. It's about empathy. It's about kindness. It's about meeting people where they're at and actually having a genuine, authentic conversation about what's going on and how you as a service provider can help them. They're coming to you for a reason. Be available to that. So what can this look like? And for me, this is, I really love this infographic because it is about reframing the behavior of not just children, but of families that we're working with. And instead of seeing children or families as willful or defiant or resistant or oppositional, they have a great many reasons as to why they aren't cooperating with your process. Our processes aren't meant to be necessarily kind and empathetic. So we really have to reframe for ourselves that, you know, is this a child who won't, or is this a child who can't yet? And again, we come back to this notion of behavior as communication. Behavior serves a purpose. Understand the purpose, and then you are better able to support a more pro-social response to what's going on with that child. So we talked a little bit earlier about, you know, it's not about what just happened before a particular behavior. It's all the things leading up to it. So in the ECU world, we look at those ABC charts, and how can we also add to those charts and start to think about, what is this child's experiences? Have they experienced trauma? What has their life looked like up until now that requires that particular behavior? And certainly if you're coming at it from a strengths-based perspective, you know, I had a child in my school age program, you know, older than the 0 to 6 population, but you could see how he had learned very quickly that tantrums got him what he wanted. And so instead of saying that this was a child who was, you know, naughty or misbehaving, this was a very clever and resourceful child who figured out, why ask nicely and be told no 10 times when I could just scream and yell and you give me what I want at this moment in time? I figured out a shortcut. So what we need to do is, before we try and eliminate a behavior, we need to figure out what purpose that behavior is serving so that we can fill it with something that's a bit more pro-social. Trying to eliminate it on its own is not going to do the trick. The need still has to be met. So again, just remembering that there are reasons for challenging behavior. Reframing it for yourself in that way will have you responding to that child in a more empathetic lens. They're not giving you a hard time, they are having a hard time. I think when we think of trauma, sometimes we think of these really catastrophic events. And for young children, it doesn't need to be a big blowout for it to be traumatic. Something as simple as leaving me in my crib crying for half an hour by myself with no reassurance that you're on your way or you're coming is traumatic. Ignoring me when I need you is traumatic. And it has impacts for the whole child, not just pieces. And so when we have these children who have experienced these adverse life experiences, and they go on, and they're not, those needs aren't met, or they're not acknowledged, or they're not recognized, and they certainly aren't getting the supports that they need, we start to see some really maladaptive behaviors as they grow older. So I think it's, under childhood, we see developmental delays, absolutely. We also see expulsion. Anybody surprised by that in young children? In North America, kindergarten has the highest expulsion rate. Are children being kicked out of school because they don't know their 1, 2, 3s or their ABCs or their shapes and their colors? Why are they being kicked out? They cannot manage the day. There's too much going on. It's a very kindergarten is very demanding. You've taken away my naps. I don't have the same friends. I don't have the same teachers. There's a bigger group, less adults. It can be really scary and challenging. And if I don't have the tools that I need to manage that day, oftentimes children are asked to leave altogether, or they're asked to do a gradual re-entry into program, or a modified entry into program. How many of you have seen that? Too many hands just went up. And these are for 3 and 4 and 5-year-olds. And of course, again, if they go untreated, we start to see that these behaviors become more and more challenging, more and more intense, more and more life-threatening for self and for others. I want us to listen really, really carefully to this little short snippet from Bruce Perry, who's a bit of a hero in the field. Oh, whoops.
Everybody, my name is Bruce Perry. I'm a child and adolescent psychiatrist and a neuroscientist. And I would like to thank you very much for asking me to be part of this 50-year celebration. I regret that I can't be with you in person. I would much rather be in Scotland with you than where I am currently. But hopefully you'll accept this. Time and time again, here's what we find. We find that if there are children who have significant adversity, chaos, threat, attachment problems in the first year of life, and then they're taken into an environment where there's consistency, predictability, nurturing, and all kinds of efforts to try to help them catch up, that those kids do worse than children that we work with who had a first year where there's consistency, predictability, nurturing, attention, love, all kinds of positive things, while their brain is rapidly developing in that first year. And then for variety of different circumstances, then their life starts to experience unpredictability, chaos, threat, exposure to domestic violence, and so forth. The outcomes of those children, even though they have more years of adversity, are better than the outcomes of children who have adversity in the first year of life and then consistency and predictability for the next 16 years of life.
When you look at building relationship and we look at the preteen age and the teenagers, and we think about some of the risky behavior that age group can get into at that age, all parents want is for their child to come to them when they need them. But that work doesn't start at that age. It starts when they're babies, when they are newborns, when they are infants. And so if, as a parent, and you can explain this to your families, Donovan, that if you're responding to the cries, to the need to be consoled, to try that diaper change, to work it out with that child and to meet their needs, and all you're telling that child is that the message that you're sending that child is, I'm here for you. I'm going to be here for you. I'm going to help you work through this. I'm going to console you. I'm going to comfort you. I'm going to be that person that you can rely on in your life. It starts then. And that relationship continues to build until that child becomes an adult themselves, who will likely still reach out to you as a parent when something's going on or when something's going wrong. That relationship doesn't happen out of the blue. It takes work and it takes effort, and it has to start in the first, like as a newborn. And as Bruce Perry elicited to said in his little spiel, those first 12 months of connecting and building that relationship is critical. Those first 12 months mean everything. So I really like this slide in particular. So if you look at the brain, we can do a quick piece around, you have your reptilian brain, which are all of the kind of unconscious things that you do, blinking, blood pressure, breathing, that sort of thing. Your limbic system are where all your emotions are. It's your emotional brain. So that's where you go to when you're having a moment where you're emotionally charged. You don't use any other part of your brain except there. You're having all the feels right there. And then your neocortex, where your prefrontal cortex is that's where your logic and your reasoning are. So you can kind of connect the colors to the typical development of the brain. So remember at the very beginning, we talked about what is infant and early mental health and what are the three components that are required. Relationships, the ability to manage your emotions and ebb and flow through those emotions, and then the ability to explore. So if you look at the typical development, you can see here that when I have good relationships, I don't have to worry so much about the survival piece in my life. I have people in my life who are going to take care of me. They're going to meet my needs. And because those people in my life, because I have that relationship, I don't have to spend so much time on worrying about regulation or even social emotional pieces, because I have people in my life who are going to help me co-regulate, and they're going to help me manage my big emotions when I have them. And that leaves me lots of time to explore the world. That means I can run around the room and pick up all the things and learn all the things that I want. For children who have experienced developmental trauma, we flip that over. I don't have good relationships in my life, so I'm constantly looking out for number one. I am the only person I can count on to meet my needs, even if I do so inadequately. Because I don't have those relationships, I have to spend a lot of time figuring out how to regulate myself and how to manage my big emotions and how to deal with them, what to do with them. I rely on me for that. And that doesn't leave me much time or energy to explore the world I live in. So I really don't put any emphasis or prioritization on learning or cognition. I just need to survive and get through the day. Does that resonate? Are you guys starting to picture children that you and families that you work with that might be having this framework? Yeah. Trauma compromises our ability to engage with others by replacing patterns of connection with patterns of protection. And again, we hear a lot from practitioners that say, you know, I hear it a lot in the EC world, I hear it a lot in the teaching world, in formal education. Oh, that child's looking for attention. Replace attention with connection, you see a different child. They're not looking for something to do, they're looking for someone to connect with. So when we go about creating these developmental support plans, the point is to customize them and to make them true to who the family are. So if we gave the same resource to all the families, we would get that equality piece. Not everybody gets what they need. But when we customize developmental support plans and we work through what's actually needed for the family, we get that equity piece. Everybody can keep trucking along in a way that works for them. The dotted line at the top, the red dotted line at the top, is about children who have experienced a good home, a home where all their needs are met, and services where all their needs are met. The solid line at the bottom is that lower trajectory. It's the experiences that are not as positive. And you can see there's a pretty vast discrepancy, but look at where it starts. Pretty much at birth. That if those relationships and those positive experiences aren't in place and they go untreated, that trajectory and that gap between those trajectories continues to expand. And past the age of 6 or so, if it goes untreated, it is very unlikely to change. It's pretty much set. So early identification can be a big game changer. So this is why screening is so critical. I did it again. So for those of you that are using any type of developmental screen or the ages and stages, this is where this work begins. We need to be able to understand where children are at, because like we said earlier, it is difficult to understand where they're at because they don't tell us what's going on. They show us through their behavior and we have to be able to interpret that. And we can't rely on our gut alone. So children who have developmental disabilities, without a screening tool, about 14 to 54% are identified. When you use a screening tool, 70 to 80% are identified. What's even more is that when we have mental health problems, which are even more difficult to decipher sometimes, without a screening tool, using people's gut, you get about 20%. But when you use a screening tool that has a social emotional component, you're catching 80 to 90% of those children. If you don't do screening for any other reason other than this slide, I think you're good. That's pretty alarming. That despite all the knowledge that many of us as practitioners come to with all the schooling or all the workshops, our gut is still not good enough. We need something else that's going to support our concerns, or the fact that we can't see them. So regular screening on all children, regardless of whether we're concerned or not, is absolutely critical. So we ask you to be curious and reflective, to really consider how your temperament interacts with those of your clients and the families that you're working with. Consider the quality of those relationships when you're working with children and families. Ask yourself those questions. Am I seeing this because we don't have a relationship or we don't have rapport? Or is something else going on? Be an advocate. Remember that so much of your role is about processes and doing things, but also really thinking positively about parents and their children and how you can best support their needs. Being relational in your practice, like we said, working with all of these people and considering all the other professions that you can partner with in order to support the whole child and not just pieces of them. Ensuring that you are working collaboratively with these various individuals who might be in the child's life. And be willing to move out of your comfort zones. We do a phenomenal job of gross motor and fine motor and language and even cognition, but we don't do a very good job with those other pieces, self-help, emotional, and social. What other ways can you attune yourself to those pieces for that child and family? And last,
The basic science of health and learning and behavior is the same science in all countries in the world. We began with a very strong science core that focused on children. There's a real window of opportunity for us to be able to try to blend the most cutting-edge science about health and development to take on the most challenging problems. For us, the issue is not so much what's the best available knowledge, but how do we take the best of what we're doing right now and say, in a constructive way, it's not good enough. In this field where we have made progress, no question we've made progress, but the best impacts we have are not completely solving the problem. It's good to be making progress, but it's not good enough until we get to the point where we've completely conquered the debilitating effects of poverty and the adverse consequences of exposure to violence or maltreatment. In the early childhood field, there hasn't been an environmental kind of sense of safety to take risks and try things. It's okay if you don't succeed, don't hide it. Shine a bright light on it and figure out why it didn't work. That's where big breakthroughs come. So we have really embraced this as now really at the heart of our mission, to create that R&D platform for a field that hasn't made it safe to try things and learn from things that don't work. We're driven by an incredible sense of urgency given the nature of the problem, but a respect for the fact that we have to be impatiently patient. We can't turn things around overnight, but we are absolutely convinced that none of these problems related to poverty or discrimination or violence or maltreatment, none of them are unsolvable. We totally reject the idea that what we're doing now is the best that we can do. It is all about finding the right people and creating an environment where we can bring them together and have the magic happen. So it requires a certain kind of scientist who appreciates a sense of adventure and risk-taking in interaction with other disciplines. It requires a certain kind of policymaker or practitioner to be a partner who says, I want to be better. Once you understand the science and you understand how not inevitable most of the problems are in the world and how preventable many of them are, it is impossible to walk away. It's just impossible to walk away.